So going global in cancer clinical research is the theme tying together today's general plenary session. And our first keynote speaker has spent much of his career thus far developing tools and platforms to enable just such worldwide collaboration. With a Ph.D. in systems design and engineering, Dr. Yuri Quintana is Director for Global Health Informatics in the Division of Clinical Informatics at the Beth Israel Deaconess Medical Center and Harvard Medical School. Among the projects he has led the development of is CureForKids.org, a pediatric cancer education and collaboration website used by thousands of professionals worldwide, and a related outreach program aimed at kids themselves, Cure for Kids, which won the Center for Digital Education's Best App Award for 2013. His talk today is titled Building International Research Capacity and Global Data Collaborations, Lessons Learned. Dr. Quintana. Thanks for coming.
Thank you very much for the opportunity to share with you the work that I and many other colleagues around the world have done to help build capacity to treat cancer worldwide. In some of the work that you'll be seeing, I developed while I was at St. Jude Children's Research Hospital, and since July last year, I'm now at Harvard Medical School in Beth Israel, developing new platforms for helping to build capacity worldwide. So as you know, there are a lot of challenges in healthcare. There are rising chronic diseases, and cancer is one of them. But there are lots of other related conditions such as mental health, an aging population. Many places don't have the adequate resources to do proper diagnosis or any diagnosis. And one of the biggest challenges that there are is that there aren't enough healthcare workers, and they're not available in the places where they're needed. So sometimes when they get training, they move to other places. And so there's a dire need to help develop more healthcare capacity worldwide. Those staff people and physicians and nurses are going to need essential medicines and the proper equipment. And they'll need tools to be able to keep track and measure the progress of what they're doing. Many of these systems are not very well integrated. We have that same problem here in the US, but it's even worse in other developing countries. And so it's very difficult for them to really understand what trends are happening and how to improve quality of care both locally, regionally, and at a national level. And the coordination of care remains a major problem worldwide, especially when you're trying to connect different healthcare professionals and provide a coordinated optimum care. And the cost continues to rise for everybody. So I'd like to sort of give you a case study of Central America. And it's a success story which many people and many institutions have contributed to in pediatric oncology. And so in the 1980s, this region had a lot of devastations with wars, earthquakes, floods, hurricanes, and so the infrastructure for delivering health care was limited. And survival rates for children was 20% or less in most centers. In the 1990s, the people involved in pediatric oncology started meeting more regularly, having annual meetings, and trying to establish common treatment protocols and work collaboratively together to raise survival rates. And they made some progress. In 2002, I had the opportunity to help launch CureForKids.org to provide not only education, but tools to help collaborate and help build this, the efforts of this community to raise survival rates. It started as a digital library with online learning education materials and quickly became a platform for communication and collaboration. And through the work of many different institutions, the overall survival rates got to 48%, and for some cancers, well over 50%. So how did this sort of happen, and what were the success factors and barriers? So there's a term called community of practice, which is a group of people who have a common interest, and they want to share knowledge and experiences to collaboratively grow both personally and professionally. And a lot has been done to study communities of practice. Medical societies and professional societies are one such example, and you may meet locally or regionally or nationally or internationally. And those are good events to sort of get the latest state-of-the-art information, but they're limited in frequency, and for developing countries, the cost of travel is a challenge for them. And there are limited collaborations you can do because time, distance, and communication. So there's an opportunity to use technology to help bring together these communities so that they can more effectively collaborate and grow together. And so typically what happens is that these communities start to communicate via email lists. They might create an online discussion forum. They'll discuss best practices. They'll try to apply that knowledge in their local context and share knowledge about how they're adapting those regimens. And as a community, they develop collective intelligence, an area called implementation science, and then they share that knowledge within the rest of their communities. So this was happening via emails, and so the idea was to build a platform that would coherently synchronize these communications and provide a place for this community to grow. So Cure for Kids was launched on April 1st, 2002, with 35 users, a few of them in Central America, some in Morocco. And over the years, it grew. And by the time I left in 2014, it had reached 40,000 users in 187 countries. It was freely available and had over 2,000 online seminars, courses, and meeting spaces for these groups. And so this platform was developed as an integrated center that had very rigorously selected online content. It had instructor-led courses, competency-based curriculums, and as well as a teaching case library. But equally important, and probably most effectively, was the collaboration tools that allowed people to meet and learn how to adapt that knowledge to their local context. And this is very important for international development, because what works in Portland or Boston may not work in Mexico and may not work in Chile because of the different resources and needs that they have. So being able to have people communicate and collaborate is essential. And this developed first with web-based meeting tools, then a second opinion system, and then a more advanced tool for disease registry and sharing of clinical protocols. The live meetings were particularly effective and useful. Over 400 groups formed over this 12-year period, and over 200 of those continue to meet on a regular basis, usually weekly or monthly. And these are groups that form around a particular disease in a particular region of the world. And the groups have anywhere between 10 and 50 people. And by having regular meeting times, they would present a case, usually from developing countries, and then experts from the region and other international places would collaboratively discuss the case and discuss treatment strategies and how to adapt protocols. And several publications, there's probably over 40 publications of the different groups have appeared that describe some of the advances that they have done in developing protocols, advancing education, and advancing collaborations. So these meeting tools are essential for not only continuing education, but also to get advice on difficult cases and for program development. And one of the interesting things is how people during the meeting, especially in the first few minutes, sort of have that camaraderie and emotional support. If you're working in a developing country and you have low resource, it can be very challenging. You might want to think about leaving the area, but that ability to sort of connect with other people who are sort of working together in similar situations tends to lift people's spirits, and then they have a sense of community and connectedness, and that community tends to stay together and grow together. Over time, this initially started with just physicians. Meetings became more multidisciplinary as a concept of multidisciplinary care was sort of promoted throughout the world. And so different nurses, other health allied workers would participate. Eventually, some of them would create their own groups. But it was very exciting to see that team development happening. And towards the later years, the senior leaders would then promote younger faculty to take over and be the leaders of these groups so that they could start thinking about transition and who would be the next leader at these centers in developing countries. So from these live meetings, there were sometimes very interesting cases that would happen, and people said, well, why can't we take those best cases, write them up as teaching cases, and have them available in a library and allow people to ask questions on that, so that if you couldn't make the meeting, you still have access to those best clinical cases and be able to engage. So a section of the site was developed called Oncopedia that has these teaching cases. Experts would select the topic, they would provide their own opinion of how they would treat it, but then the case would go live on the website, and it would have a discussion forum where people could ask those follow-up questions and interact with the authors and other experts in an asynchronous fashion. And then one of the most important pieces of all of this was the ability to have tools to collect clinical data and analyze them. Most of these sites do not have electronic medical records or tools for disease registries. And in the case of Central America, different people had different databases and spreadsheets, and so when they would get together every year to compare outcomes, it was very difficult because they were in different formats. And so a site was developed called Pond for Kids, which allowed you to have a private site for your own clinic to have your clinical records. And then the sites that had participated on creating common protocols created an electronic roadmap for that protocol and put it in a shared library. And then everyone from those countries could pull those protocols and then use it to sort of track their patients using that common template. This became a very popular thing, and more people started sharing their protocols. And over the years, well over 100 protocols were made available from different countries. People would also agree on what kinds of clinical forms they wanted to use for different studies and put it in the shared library. There were tools for doing basic statistical survival curves and other analytical reports. As people came up with these kinds of reports, they'd be able to create a specialized link on the shared library so that other people would be able to generate similar reports on that. And then there was an area for groups to share documents. And so there was not only sharing of education, but now there was sharing of treatment strategies in a systematic way. And the system allowed you to share clinical data in de-anonymized formats. And so if you wanted to share how your patients were doing in a particular protocol, you could share it with other investigators who were doing the same protocol, and they could all see each other's survival curves with de-anonymized formats. And so groups would use this tool for their own clinic, and then they would choose to participate in one or more cooperative trials online. They didn't have to, but many of them did. And then they would have weekly meetings to see how their patients were doing in those collaborative trials. The Central Americans already had that culture of collaboration and are still probably the leaders in this area in terms of the most number of common trials. And they started collaborating with other centers, not only in the United States, but other parts. And very soon, other regions of the world in South America and in Asia wanted to sort of use that kind of methodology and tools for sharing knowledge and having common protocols. So the evolution of these communities of practice really sort of goes through different phases. And the first part is this phase of connecting with each other, sharing education, and sharing opinions on difficult cases. The second sort of evolution is when they start getting together on developing common protocols and using tools like Pond for Kids to sort of share those protocols. And then as they became more trusting of each other and closer colleagues, they would then actually invite each other to review their patient charts records and bring other people for quality improvement reviews. And so this, over time, developed into a very deep, trusting relationship. And it's very different than having somebody sort of show up overnight, critique their center, and not really have an understanding of the context. So there's an evolutionary process for these communities. And one of the things I'm doing now is studying how these evolutions of communities work. Why is the 200 of them continue to meet, and what happened to the other 200? So I'm building new platforms that make it easier for people to share knowledge. This new platform will be more mobile friendly. It'll have better technologies to be sensitive to bandwidth. But it'll also allow people to see how their community is evolving and where there's better engagement and where perhaps the engagement in their community is dropping off. And my interest is to understand how those communities evolve. So we did one publication that sort of documented some of the factors that were in the evolution of this community, and the references below. And one of the most important parts is that these people had a common goal and had put in their schedules a regular meeting time where they would meet and connect. They were not only sharing education, but sharing clinical data on outcomes. And these collaborations included not only physicians, but nurses and other groups. So it became very interdisciplinary. The outcome of this network is that they have now survival rates in the range of 50%. They've been able to integrate this collaboration and culture of learning and collaboration to other disciplines. The multidisciplinary team concept, which is prevalent in developed countries, is now expanding in developing countries. And it's had a multiplier effect in the sense that not only did it have a positive impact in cancer care, but other diseases in nearby hospitals saw it and started sort of following similar processes. So you can impact one disease, but you can have a multiplier effect on other diseases in other parts of the healthcare system. And then other very innovative things were developed. For example, late referrals is a major problem in developing countries. And so different groups who had developed innovative strategies for having community outreach and getting earlier referrals shared their practices. And then other countries were able to replicate the way they were able to improve referrals and get sooner referrals. Other issues that were shared was how to deal with toxicity, and many groups started sharing that knowledge. And there's probably another 40 publications from the different groups on some of these collaborations. So generalizing this to communities follows kind of the similar pattern of initially connecting, people starting to share knowledge, evolving towards tools that allow more peer-to-peer support, and the sharing of practice guidelines and the ability to adapt those guidelines to local needs. And then as you develop more trust, then having tools that allow for more detailed second opinion systems, and for having your peers come over and review your processes and methods and outcomes for quality improvement. The facilitators of this is when people come together and have a set of common needs where there's transparency in the mission, where leaders are inclusive and start thinking about mentoring new leaders, where the focus is not on who gets the credit, but how widely you can share knowledge. There has to be also a process of having a dialogue of what are the common terminologies and classifications. So for example, things like race, different countries classify race differently. Different people sometimes code cause of death differently. So there has to be a communication and agreement of that community of how they're going to classify and information so that you can do meaningful comparisons. And above all, I think there has to be a community that's responsive. And so when somebody asks a question, one way to tell engagement is how long it takes for that community to have someone come forward and give an opinion and share support. Some of the barriers to the developing a community of practice is sometimes misaligned goals and needs. Sometimes you have very dominant personalities that promote their own sort of agendas, inflexible management, hidden agendas, and sometimes having a community that doesn't respond to each other's needs, or having leaders that do not mentor the next generation of leaders who are going to support that community. So what I'm currently working now is new platforms that will not only support education and clinical collaboration, but also tools that will be able to, for community outreach, for how you go about tracking your efforts of community outreach and improve late referrals. And so these systems need to be connected so that then you can do a geographical assessment of where your referrals are coming, where are the problems, and how do you adjust education and community outreach, especially in developing countries, so that you get early referrals. The clinical system will be more integrated, so instead of having separate systems where you have to copy-paste from one to another for your weekly meeting or second opinion, they'll have better ways to import and export data. And one of the key things is also to allow software so that you can have system in your own country or in your own center, and then synchronize to the cloud. And if you have privacy rules that prevent you from sharing identified data, then you can synchronize just de-identified data. But some countries increasingly have stronger privacy laws that prevent the export of clinical data outside their country. So this is a distributed architecture that's more mobile friendly and gives more granular controls. And then finally, there's a piece for follow-up care, and I'm working right now in two areas to sort of apply this. One is in maternal health, and so the system's being built to sort of track difficult deliveries and children who are in intensive care, but then afterwards who need to be followed up. a way for that midwives and parents to sort of be able to report back. And this is sometimes called patient-generated information, and to have these systems all interconnect so that the information can be seamlessly shared. This is a major challenge also here in the United States or anywhere else. It's sometimes easier actually to prototype these things in developing countries where there isn't technology, and you have people that really want to collaborate. And so I really enjoy what I do because I get to work with people that are really motivated, open, and are willing to innovate. So what are some, to summarize, what are some of the challenges that have been learned by myself and colleagues in some of these projects? Well, one of them is trying to collect too much data initially. It takes a lot of effort to collect data and to verify data. And so I think starting some of these international projects, you have to start more modestly and collect less data. You need to think about whether there's legacy data and how you go about collecting that data. And you need to have tools and processes for how you review that data. Part of that is also providing a change management culture, and how do you go about introducing quality? Because if you go in very sort of hard edge saying, you know, this quality is not good, and people will feel criticized, they won't feel engaged. So there has to be some sort of strategy for how you engage people and introduce the concepts of quality and get people motivated so that they don't feel it's punitive, but they're being encouraged to improve quality. The sharing of data internationally, also you have to deal with different international units. There are different medical vocabularies and taxonomies. Race is one example of that. People do want granularities of control, so they don't want to just share all data or data. They may want us, for example, for only pathologists to access pathology data. They may want to share only parts of the record, so you need to build systems to have that sort of level of granularity. You need systems that can be used locally without the internet, and then synchronize. If you have to, internet's still unreliable in many parts of the world, and you have to deal with inconsistent bandwidth, especially in places like Africa and other places where they just don't have the kind of internet speeds that we do. Some of the people challenges is really the availability of technical staff. You know, even in the United States, it's getting or anywhere, it's very difficult to sort of provide internet security and to find people who can keep up with the speed of how you need to set up firewalls. Even deploying any sort of technology area, there needs to be a plan not only to train doctors and nurses, but the staff, the IT staff and informatics staff that will be able to manage that data. The training has to be in different languages, in local languages. So while the physicians may know English, some of the nurses may not. Most of the data managers probably do not know the English, and so you need to provide training in their languages. Retention of staff is a major problem in international development. So as soon as people get trained, if they get better, they see better opportunities in bigger cities or other countries. And so there has to be some sort of strategy for how you're going to keep that staff engaged. Sustainable funding is a problem. Sometimes country governments, you know, default on their payments to their clinics. And so there are some innovative ways to have local foundations provide stable funding for continuity of services. I think one of the key things for any collaborative group is to have consistent communications. So meeting regularly is important. There are cultural differences, and so you just can't take people from different parts of the world, maybe who don't quite get along, and expect them to all of a sudden just instantly start collaborating. And so you have to be respectful of cultures and let time sort of help build that trust so that people can collaborate. There are semantic differences. So what we mean by urgent in the United States might be different when what they mean is urgent in Germany or other parts of the world. The word abandonment might mean different things. And so you need to be sensitive to what the words mean. There also has to be models for how you govern the network and how do you do data sharing. And that has to be done as an engagement strategy, not sort of a dictatorial strategy. And above all, people need to trust each other. Without trust, you cannot develop these communities. So to summarize, some of the lessons learned with some of these international projects is that you really need to have achievable goals and need to take into consideration what are the local resources. The community as a whole needs to agree on what are the common objectives, and it can't be just one stakeholder's primary objective. There has to be a community agreement on those objectives. You need to have plans that include timelines and ways to measure those programs. You need to develop programs that meet regional needs, and that takes time to understand the local context and what are their actual needs and environment. And sometimes you don't actually see that on a first visit. You might take 4, 5, 6, it might take 6 months or a year or 2 years before you actually fully understand that environment. There also has to be strategies of long-term commitment on both sides, and there have been too many studies where people go, do one study for a year, and then leave, and the infrastructure is left, and it's left a lot of bad taste in a lot of people's minds. And so if you're going to do these projects, there has to be some sort of vision of how you're going to sustain this effort over a long period of time. And training and career development is very key, and this is tied to the retention. So everyone from the data managers to nurses and physicians, there has to be a strategy of how they're going to be rewarded and incentivized to stay. Something that people don't put a lot of effort but needs to be important is how you do change management and do that in a culturally appropriate way. And above all, you need to really develop platforms that are really easy to use. You know, lots of people complain about their medical record. If you're new to technology, putting a very complicated system with tons of features may just overwhelm people, and you may never actually get started in those projects. So you need to develop interfaces that are easy to use in their languages, and that can also then later on scale. So sometimes people think, oh, we need to scale, so they buy something very complicated, and it doesn't get used. You need systems that can gracefully expand from a simple-to-use system to a scalable system that you can use regionally or nationally. So I'd like to thank everyone for your invitation.
Please stay, I don't know if people have questions.